Okay, I think we can get started. The beginning is some housekeeping and welcome and introductions, and I'm sure some folks will still trickle in. We are very excited to have Patty Lee King with us today from the Illinois PQC, who will be talking to us about their experience implementing patient-reported experience measures, or PREMs. So we will definitely learn a lot. And so excited to have her with us. Next slide. So if everybody can just type their name and their institution into the chat, that would be great. It helps us also with recording attendance, but also for folks to kind of see who else is on the meeting. Please do mute yourself when you're not speaking. And during the presentations, please feel free to type your questions into the chat. We will definitely be monitoring that and can answer them as we go along. And this session is being recorded, and it will be uploaded along with the slides to the Penguin website afterwards. And as always, CME and CEU credits are available. Next slide. And even though we are deep in the midst of our equity bundle, it's never too early to start thinking about what we would like to do next. And so we have created an AIM bundle interest form with a list of available AIM bundles. And we ask that you rank the topics that you would love for us to think about when we start our next AIM bundle sometime next year. It does take a lot to play on and to prepare, so that's why we're starting now. And there is a QR code here, but the link to the survey will also be in the chat, and it takes no more than 2 minutes or so to answer. Next slide. So I am standing in for Audra today. I have really big shoes to fill, and I'm not going to do it justice, but I will try my best. So after this, we'll go through the structure measures that were submitted in January's survey for the AIM bundle. And then I will pass it on to Patty Lee King from Illinois, and then we'll wrap up with announcements and upcoming events. Next slide. And just a huge thanks to our ever-growing Equity Bundle Work Group, who meets after these monthly webinars and at other times during the month to really help us think through, debrief after webinars, think about things that we want to address in upcoming webinars. So huge thanks to this group. Next slide. And super exciting that we are now up to 22 hospitals that are participating in the equity bundle, which is just phenomenal. So 22 out of the 40 hospitals in Massachusetts, which is great. Next slide. So now we'll go into the data review from what was submitted in January. So next slide. And this is just a reminder, so especially for those that may be new to this work or to our bundle. So the submission is done via Betsy Lehman Center, which is our collaborators who are function as Penguin's data repository. And the only thing that's required before you submit data is to sign a memorandum of understanding with the Betsy Lehman Center to submit data. And then each month, at the beginning of the month, you'll receive an email with this survey introduction. And the survey is open for the first 10 days of each month, where you can complete both and submit your structure and process measures for the equity bundle. There's also bundles that we have done in the past, such as hemorrhage, hypertension, and opioid use disorder. So if you are still implementing those bundles, still doing work around those bundles, those are also included in the survey, and you can submit data for that as well. And these are typically completed by your OB or nurse bundle champion or a QI data member on your team. Next slide. And just to highlight this, so prior to January survey, each structure and process measure required an answer in order to move on. And so you could not submit the survey if you didn't answer every single question. What we heard from your feedback is that, especially for some of the process measures, in some cases, your electronic health record didn't allow you to, for example, stratify by race or ethnicity when you were looking at the hypertension process measures, for example. So in response to your feedback, and so people who couldn't do that just couldn't submit the survey. And so what we did is we added radio buttons for the process measures. And this allows you to answer a question saying, no, you can't complete this because you don't have the data or you don't have access to the data. And we simply just ask a quick question as to why. So now everybody can complete the survey and submit it, even if there are certain questions that you just can't simply get the data for. So we're hoping that this really helps. And we'd rather have surveys from all the hospitals participating, even if some of the data just can't be submitted. Next slide. So we'll go over the structure measure. So we had 11 hospitals submit data this past month in January, and 7 now of the 11 teams that submitted the survey have now formed an equity team in their facility, which is great. And you can see it's that percentage has, even though not every hospital submits data every month, you can see that that percentage has steadily increased over time. Next slide. And in terms of having an anti-racism statement, 3 of the 11 hospitals do in fact have one in place, and 4 of them are currently working on that. Likewise, when it comes to SMARTY goals or an AIM statement for the equity bundle, two hospitals have created that, and there's another 3 or 4 that are currently working on that as well. Next slide. And this is fantastic. Almost all of the hospitals that did submit data for January did report collecting race, ethnicity, and language as part of their demographic data collection. Next slide. And of those 10 that are collecting it, 100% report that they are collecting it as a self-report from the patient themselves, which is great. And then collecting the demographic data is one thing, but then really it's what we're aiming for is that we can use this to look at different data measures stratified by race and ethnicity and language. And so right now, there are hospitals that are currently doing that, and the majority of the hospitals that submitted data are actually working to implement this data stratification. And very appropriate for today's topic, 7 of the 11 hospitals have implemented a PREMs. And again, you can also see this sort of rising since we launched the equity bundle in September. So for the 7 that have implemented it,
Listen, I can't hear you. I'm not sure if others can.
Can others hear me?
I can hear you.
I can hear you, Kristen.
I can hear you too.
Yep, it's fine.
Audio works fine.
Okay, sorry, Ron, I don't know.
No, you came back.
Oh,
Thanks.
okay. So as I was saying, for the 7 that are have implemented a PREMs, I think today will be really helpful in terms of working through some challenges or answering any questions that may have come up since you've implemented it. And for those that are working on it or have not yet started, today will be a wealth of information and some tips and insight from Illinois in terms of how to actually do this at your institution. Next slide. For those hospitals that have implemented PREMs, these are the types of PREMs that they have implemented, and the ones that kind of stand out consistently are HCAHPS, Press-Ganey, likelihood to recommend, Qualtrics, and then actual hospital patient satisfaction scores or surveys that the hospital themselves have implemented. And then for those that are participating in the Team Birth Initiative, they are using those PREMs as well. Next slide. So it is first of all, I guess, are there any questions, and Kaylee or Claire, if you're monitoring the chat, were there any questions about the data? No. Okay. So it is my real pleasure to introduce Patty Lee King, who's our guest speaker today. She is the State Project Director and Quality Lead for the Illinois Perinatal Quality Collaborative. She has been with them since 2014, and she has 20 years of experience facilitating program development and implementation in local and national settings using quality improvement and implementation science, with a real focus on health equity, maternal and child health, mental health, and health policy and communication. She serves on the Illinois Maternal Mortality Review Committee and the State Quality Council, and is advisor to many state perinatal quality collaboratives across the United States through her work with National AIM, and then the National Network of Perinatal Quality Collaboratives. And so without any further ado, I will pass it on to Patty.
Thank you so much. I'm so happy to be here. Can everybody hear me okay?
Yes.
All right, awesome. So it was really helpful. I'm so grateful that I got to see the data and get a little context. I probably will go off slides a couple times to highlight a couple points that I'm not sure I put in the slides that might be helpful to show how we're doing the PREM in Illinois. But happy to be here, and I think we can go to the next slide. So just a couple of brief points on ILPQC background. Next slide, please. So ILPQC has been around since very late 2013. So we just celebrated our 10th annual conference anniversary in last November. We are, similar to Penguin, we're a statewide network of perinatal clinicians. We have nurses, hospitals, patients, community stakeholders, and public health leaders that have been a part of our community, and we work together to implement data-driven, evidence-based practices. And we really focus on equitably improving outcomes and reducing disparities. And so Birth Equity Initiative, we've been doing equity work through initiatives since our beginning, but the Equity Initiative is, for us, the Birth Equity Initiative is really an intentional step to make sure all hospitals have the foundation and infrastructure to focus on equity through all of their work. And we have about 100 birthing hospitals in Illinois. Nearly all of them participate in one or more of our initiatives at any given time, and they're distributed all over the state of Illinois. Next slide, please. So this is a little bit about the context in our process. We, like you, spent a lot of time reviewing national guidelines, evidence-based practices related to the different initiatives that our hospital teams select and vote on to do. And then we collaborate with our stakeholders in Illinois and nationally to make sure that we're doing the initiatives that are addressing the maternal and newborn morbidity and mortality issues that families in our state are facing. So the Birth Equity Initiative was no different. We used a lot of resources and talked to a lot of people, including you, to think about how to do this work and learn from each other. Next slide, please. So one of the themes of my talking about the PREM is going to show how related it is to so many of the other strategies of this initiative. One that I'll emphasize the most is really the work of engaging patients, families, and communities in quality improvement, and specifically in our Birth Equity Initiative. But I did want to give a little bit of context to our journey with doing that, because it has been a process that we're constantly evaluating how to do better and have evolved and changed over time. And so a lot of the stuff I talk about today will be with that kind of context and history in mind. But we started with our second annual conference. We started with the patient and family engagement breakout at our conference, kind of recognizing the importance. And then through all these years, really been trying to figure out how to better ensure that patient and community voices are integrated into our work and are driving and informing our work. So we did a lot of tool development to help hospital teams engage patients and families. We moved to doing a pilot where we would actually match interested community members and patients with hospitals to work on quality improvement or to share stories. We developed a toolkit that is available on our website. And then we did a pilot of the toolkit with Latasha Roos, who's a national leader in this area. and also held patient focus groups on our QI tools. We started to do regular patient focus group feedback on the tools that we developed at the collaborative level. So this is really a mix of both hospital level supports and then collaborative level actions. And then in 2022, we did 10 regional community engagement meetings. We just presented some information on this at a conference about how we did this work. If you want more, I'm happy to share it. Our state has a regionalized perinatal system, and so we did meetings where we really tried to model patient and community engagement to the different regions and match them and connect them with community and patient stakeholders. And then we also have started community advisory boards with our obstetric team and our neonatal team, and they've met multiple times in the last several months. Next slide, please. All right, so let's get to the Birth Equity Initiative and the strategies you want to hear about. So just again, a little bit of context. This is an initiative that was selected by our teams in 2019 with input from our maternal mortality review report and our other state stakeholders. 86 of about 100 at the time. I think we're a little under 100 now, or maybe right around it again. Hospital teams are participating in this initiative specifically. We did a lot of prep work through 2021 and worked with 14 teams that agreed to kind of test some strategies and toolkit resources, as well as the data collection process in early 2021. And we launched this initiative with a webinar in 2021 in June, and then started monthly calls and data collection after that time. And again, I've mentioned that this is really intended to be like, it is some foundational skills. It is pulled out as its own birth equity initiative, but really meant to be something that translates. And we're already showing hospitals how this work is a part of all the different initiatives they do with ILPQC. Next slide, please. So our aims, our goal is to, by the end of this year, and we always adjust this if we don't meet our goal, but the goal is by the end of this year that more than 75% of the hospitals in our state will be participating in the initiative, and that we were able to do. We really just wanted to make sure everybody came to the table and got engaged in this work. And then we also, our goal that we're working on now is that more than 75% of the hospitals will have key strategies in place. And so this is different than other initiatives where we have a very clear clinical outcome. We really are focused on making sure they have the infrastructure in place. So it's very much rooted in structure measures, which I heard you talking about and measuring earlier. So the 4 key drivers are addressing social determinants of health, reviewing race and ethnicity and medical record and quality data to drive improvement efforts, promoting patient-centered approaches to engage patients and communities, and to develop respectful care and bias education for providers, nurses, and staff. And despite the name that doesn't actually say it, most of our conversation today, I think almost all of the things we get into deep on are going to be in that yellow arrow, that driver. Next slide, please. So we have our drivers, and then we also wanted to call out some key strategies. We do this a lot with our initiatives to really help hospitals focus on what they're doing early on. All of these strategies, kind of a one-for-one match strategy to driver. We have other strategies, these are the key ones, with the exception of that yellow arrow again. There's 3 of our key strategies that are within that. So that yellow driver is where a lot of the really hard work is happening. So some of these we've highlighted, right? But we are working to help teams optimize race and ethnicity data collection, both how they collect that data about race and ethnicity, and then what they do with it to make sure that they're improving, addressing disparities and improving. We have universal social determinants of health screening tool implementation with linkage to resources. And then the 3 that are related to that work about patient-centered work is really the 2 middle and then the next. So the orange box, share respectful care practices on labor and delivery, and then survey patients before discharge on their care experience. And that is where we're using a patient-reported experience measure for feedback. So we see our respectful care practices and the feedback on them very related, which you'll see very much in the following slides. We also, the highlighted in pink, engaging patients and community members for input on quality improvement efforts. We're really tying the work of respectful care and patient-reported experience with engaging patients for our hospitals. We really hope this is the initiative where hospitals have the tools they need to effectively engage patients and community in their QI work. And then standardizing postpartum safety education and implicit bias and respectful care training. Next slide, please. So just wanted to show you a little bit about where we're at and where we've come from. So these are our structure measures in shorthand. They're all related to hospitals implementing changes in how they do work and care processes to get them set to be successful in improving processes and outcomes. And we've improved on all of them, which is great. We have not met our, we don't have as many teams at the goal yet as we want on some of these because we're not done yet and we're focusing a lot on that. So some of this, I'm going to go into more detail in the following slides on the structure measures related to our conversation today. So I think we can advance to the next slide. So this is how we look at structure measures. It's not too different, I don't think, from how you look at it. So the hospital teams, each month they go in and indicate if they have a structure measure in place. So a system's change in place. If they're working on it, which means it's not in place, but they're actively thinking about it and trying to make change. And then the red is they haven't started working on it at all. And these are as of December, which is like, for us, the most complete data available. Not quite ready to say January is complete. There's a significant lag in the data. But this first structure measure related to PREM implementation is really about hospitals engaging patients and community members to provide input on quality improvement efforts. And this is our hardest. This is always hard. This is the first time we've actually measured this on a monthly basis with our teams, and it's a hard one to move, but we are making improvement. And especially after the occurrence of the regional community meetings, which were all wrapped up in July of 2022, we are starting to see improvement in that. Next slide, please. So similar graph has changed. Again, another structure measure related to PREM implementation. This one's focused on hospitals that have strategies for sharing expected respectful care practices with delivery staff and patients. And again, I'm emphasizing the patient engagement and the respectful care practices because we see them as just a part of how we actually implement the PREM. So here again, we've seen tremendous growth in 2022 and feeling really good about where we're at with making sure that hospitals have a system to make sure their clinical teams and staff have information about sharing expected respectful care practices. I'll show you some of the tools we provided to help them with that. Next slide, please. And again, very similar, but it has changed. This is actually the percent of hospitals that have implemented a patient-reported experience measure survey. You'll see there's a little bit of a difference between who reported implementing the survey and who have actually started to get survey feedback back. This is a little bit more, but again, we're seeing a lot of growth in 2022 and feeling good about where we're at with teams here. Next slide, please. Okay, so some of the tools we've made for helping hospital teams engage or share information about respectful care practices with their clinical team and their patients. These are mostly focused on, it's a little bit of a mix, but largely focused on patients. So to date, and this is the accurate current information, there's another slide that has a little bit outdated data on the same point, but we have about 1,500 PREM surveys back from patients across 45 hospitals. So what I want to pause, and I didn't include, but should describe is for our team, for our collaborative, we did provide a specific PREM related to experiences for this initiative. It is modeled after the New York State Perinatal Quality Collaborative PREM, which was informed by some validated tools that I'm happy to share more details on if people are interested. But it is a survey. It's about 13 items with some demographic information. It is specific to the collaborative and the initiative. It is anonymous. Hospitals are asked to distribute it with a QR code. The patient can do it on their phone or on a tablet provided by the hospital, but they do it independently. And it is the information they put in comes to our data system at ILPQC, where with no patient information, but where we can look at the data by race and ethnicity and insurance status. And the hospitals can view reports of how their responses are through our data system. So that is how we do the PREM. Back to respectful care tools as well. And you can see this better in another slide, the actual words. You can't see the words, you can kind of see the graphic. On the left is a poster that we helped develop and distributed to teams, gave them a supply to put up in their labor and delivery rooms. So we gave more to hospitals that were bigger so that every delivery room could have them. The middle is like a guide for what the PREM questions are for the clinicians so that when they're implementing it, they can see the questions and understand it. And then on the far right is a QR code where we have through some resources and New York's leadership as well. We've got it translated into 6 languages at this time. So you can put the QR code specific to what you want to, what the patient needs. So we have a different handout that shows that. Next slide, please. I'll tie all those tools together in a moment. So there's a little bit more data we wanted to share. So we talked about the systems change with the structure measures. We also think a lot about clinical culture change with ILPQC's work, and really we see education as being a big piece of that. And so this is where we're at right now with healthcare team implicit bias and respectful care education, which is very much related to the implementation of the PREMs. So I wanted to highlight it. And so each line is a different group. The blue is providers, the orange is nurses, and the gray is other staff that work in labor and delivery and postpartum. And we are really thrilled at where we're at. We did provide a whole kind of tiered set of resources, from e-modules to tools for discussion to training. I think you guys have used the Speak Up training. We trained some team members out in the hospital teams to be champions, and as well as videos we provided for them to facilitate discussions. Next slide, please. Before I get into the process the teams are using to implement the PREM and how they're doing it, I wanted to highlight a question that came from you to me through Claire, I believe, about how education is being implemented. So I wanted to show the data and then tell you a little bit about how hospital teams are doing this before we get into the PREM. So I actually asked around to some of our hospital teams to get very specific examples, but it does seem like there's pretty much consistency, and this seems consistent with some of our other initiatives as well. So there was 3 main strategies that hospitals were using to help get education out to their staff. And the first is skills days. And they used existing skill days to present on implicit bias and respectful care practices to the entire staff. And they collected information on who participated with the sign-in. And this was a good strategy for the RNs and other ancillary staff. They also did assign diversity science e-modules, which was one of the e-modules we promoted. We also promoted Think Cultural Health. They're both free, but we did enter a relationship with diversity science to provide some consulting and resources to teams to implement the e-modules into their own learning management systems, which allows the teams to track who participates. And this was a strategy they used for both nurses and physicians. And then in addition, grand rounds is something a lot of our teams have done. We provide a grand round slide set. We also have a grand round speakers bureau that hospitals can choose to request from us to come out and do grand rounds if they don't feel like they have the right people in their hospital system or in their hospital. And this is required, the grand rounds are required, and they were able to do a sign-in at arrival. They thought this was very helpful for physicians, more helpful than their other tools they had at their disposal. Next slide, please. So that was to be responsive to a question about training. Back to PREM, which is it's all related, so sorry. So regional community engagement meetings, I talked about how my kind of process is going to really show about how patients and community members are a part of the patient-reported experience implementation process. So this is some of the information we shared recently at a conference, and we took a closer look at. But we did have 10 regional community meetings. They are located, there's none are covered up, so all the orange stars capture them. These are the location of the regional perinatal centers, central hospitals in the state of Illinois. One is technically in Missouri, but it serves Southern Illinois. And they happened between February and July. We had 29 community members and panelists, patients and panelists participate. They were not the same. There wasn't 29 for each meeting. It was a pool of 29 that were selected based on their proximity to the perinatal center and their location and engagement in that community. 77% of our teams participated in this process through these meetings. This is basically, we partnered with a community-based organization, EverThrive Illinois, to facilitate a conversation with patient and community panel members and the hospital teams. One, about how to engage patient community member voices and their value, and then two, to go through some of the key strategies that actually facilitate discussion where the patients and community members share feedback on how hospitals are implementing different strategies. And this alone got us a huge growth. I know our structure measure on this is still a long way to go, but we went from like no teams doing work in this area to significantly more. And so the percent increase, the impact of, again, if we're not to our goal yet, but we've got a lot of people involved, and the teams found it really helpful. We did ask through an annual survey, which almost all of our teams participate in, if they found this valuable, and they did. And so I hope to see this be a foundation for the work with the PREM. The next slide, please. So here's where we're transitioning. Engaging patient and community voices is important. Hospitals' understanding of the value of patient-reported experience measures comes from hearing from patients about their experiences. And so we've created a lot of strategy ideas for hospital teams to better hear from the patients' communities about their experiences at the hospital. And there's lots of levels, and hospitals are choosing different ways to do this. But we're kind of focusing a lot on specific strategies at the point of this triangle and really tying it into their work with respectful care and implementation of the PREM. And so inviting patients or community members to share at grand rounds, to share a story, organizing patient focus groups to provide input on their respectful care experiences and the respectful care practices that the hospital is implementing, and then hosting community meetings and breakfasts where we bring clinicians and providers, nurses, staff, and patients together for a moment in a simple way to share experiences of respectful care and how they relate to their work. So our key mantra here is like, just get started. Next slide, please. So these are our respectful care practices in a little bit more readable form. You guys have the slides. Please reference them. I'm not going to read through them, but these were developed with input from our patient focus groups and our community advisors. And these are shared with the clinicians, the doctors, nurses, staff, and as well as the patients through posters and other tools, which I'll show. Next slide, please. So we really think of the PREM implementation as a process, again, linked with community and respectful care practice buy-in. So kind of have this model, right, where there's respectful care practices that are shared with the providers, staff, and the patients. There's a PREM survey distributed through a QR code given to a patient. This is not how it looks. This is a red cap screenshot, but they have a little bit of different appearance. Actually, it's not a red cap screenshot. Those of you who know red cap would know that. But it is like a PDF version of the tool that we developed. In red cap, it looks a little bit different. So the patient gets that and they complete it, and it's meant to really, again, continue the dialogue in a safe way for the patient and for the hospital to look at opportunities to improve. Next slide, please. So how are teams doing this? This is an example from an actual respectful care buy-in activity that one of our hospitals did. So these are nurses from that hospital sharing or signing off on respectful care practices. So in the background, there's a sign that one of the staff is holding that has the data from the PQC data system that the hospital team is looking at related to how they're doing on the patient-reported experience measure. So that's patient-reported experience measure data back from patients who have completed it about where there might be opportunities for improvement in respectful care. And the other staff person is signing off on a poster of the respectful care practices, indicating their buy-in and support to practice respectful care practices. So again, linking the patient-reported experience measure and the respectful care practices. So these posters are posted in clinical and patient areas. They have they review them and activate them with the team through activities like this. They're intentional processes where they look at data, they sign off, facilitate the sign off on practices, and then they share the data. Next slide, please. This is an example of a sign-off template we provided to hospital teams. It has the same respectful care practices as a poster, and it indicates a commitment to practicing these. Next slide, please. So respectful care buy-in is important to implement the PREM because we rely on the people who are working with the patient to make sure the patient completes the PREM and sees the value of it. So you need the clinical team to value it as well. So ignore the blue box in the graph. It's old. It's not the larger number 1,500 is right. So we've gone from 500 to 1,500 in 3 months. So it increases quickly. We have 61% of our teams are providing expected respectful care practices to patients based on this, our recent survey. And then you can see here, the reason I kept this blue graph, and this was shared at our annual conference, so it is a little bit out of date, but the distribution hasn't changed much. So of the hospitals that have implemented the PREM, which are on the x-axis, including the zeros, and again, this was as of November, so it's a little, so the data would have been probably based on August data or September data. But you can see there's a real variation in how much they've been able to get the percent of their birth volume that have completed the survey. And we still kind of have like a quarter of the birthing population completing the survey is still kind of our high end. And then there's, you know, many people in that 5 to 10% area. And then there's some that really, they've implemented it, but they're not actually activating it. They have like the system in place to do the PREM, but they don't have people completing it yet. Next slide, please. So we really focused a lot at our annual conference on, okay, how do we actively implement respectful care? What's the whole process? And the PREM is a part of it. So we need to make sure they have a process in place to implement the PREM, and that they work to increase the completion of the PREM. And so the completion rate, we actually now have a report for hospital teams to see the percent of their birth volume that is completing, percent of patients that have delivered in a given month have completed the PREM. We're working towards 100%. That's the goal, right? Get closer to that as close as possible. That they have a process to share data back with their teams, and that they discuss and decide actions to increase respectful care, focusing on the areas where there's disparities in experiences of respectful care. Next slide, please. And so launching the PREM is a piece of this. So taking that next step, really focusing on that building clinical team buy-in, which is all about buy-in into respectful care and how the PREM provides us meaningful real-time feedback on our implementation of respectful care. The next piece is making sure that you have good access to the QR code and that you're promoting it and disseminating it to hospital teams. We have a flyer for that. That's really, I think, really helps with that in a moment. That I'll show you. We want to make sure that there's a process flow in place for the PREM. So just having a QR, we all know that having a random QR code in a room is not going to get everybody to complete the PREM. So who is the person who brings up the PREM over the course of care? How do we make sure patients' questions can be answered and that they have the tools they need to complete it? So you need to point people for those important parts of the process. And then this is an example of again, making sure that that process flow is discussed with the team and everybody knows their role. Next slide, please. Some of the teams have shared strategies through our survey recently about how they're doing it. So I wanted to share these with you. Again, they're really focusing on who is going to request the patient complete the PREM survey before discharge. Where does that happen in the process? All the things that need to happen between delivery and discharge. Make sure that they have the QR code very available. So handouts are common, table tents, which are, the one we show is based on, an English language one and a Spanish language one, but making sure that you have all the languages available. Having laminated flyers posted in the postpartum room, and then QR code in the discharge folder. Those are some things hospitals did. And then the key here is that the QI team is monitoring completion rates of the PREM and reviewing their data, and then sharing that information with the clinical team to increase both the completion of the PREMs, we can get more data, more feedback, and then also address respectful care practices. Next slide, please. I think I'm getting close, and I apologize. I meant to check when I started, so I think I might be getting close to time. This is the patient-reported experience measure survey handout we developed more recently. It is available in our toolkit online as well. It's meant to be a tool to help the care team make sure the patient knows about the PREM, as well as make sure the patient knows what to do to access the PREM. So it's really meant to remind both the care team and the patient about the PREM and to get it done. The idea is that the nurse provides this to the patient. So we have a point of contact to make sure the patient gets this and that answers questions about the PREM survey. It has direct links to all the different languages and can be customized like all of our things can. So these are the idea at the top. It does have more words maybe than your average flyer, but the idea is that the talking points help the person on the care team that's designated with this role to understand what they're trying to communicate. And as they get more confident and comfortable, they may need less of this, but it's really meant to be a tool again for both the care team member and the patient. Next slide, please. So these are, again, I'm trying to give you what the teams are actually experiencing. It's great to hear from me in my role where I'm not actually in a hospital implementing this work. So we want to make sure you have those examples straight from the sources who are doing it. Some of the things the teams are doing to share the respectful care practices with their clinical care teams are the posters. So the posters are a helpful tool. And the thing that I think they really giving them to the hospitals and them having them pre-printed in a poster form was helpful. They're doing education on respectful care practices, and you can see that in that education graph. Everything's related. Getting that education out there, including respectful care practices in the implicit bias education is a key piece of that. Making sure that staff read and sign respectful care strategies poster or the handout, whatever tool, but they've seen it. There's this intentional commitment to it, and that respectful care practices and survey data are shared with the team. It says initial PREMs survey data because you want to get people early on, but you want to keep that ongoing as well. And their example here is, again, to get people together with that initial buy-in with some kind of community like food or an existing forum where you gather people to get them to sign off on this. And then with patients, the poster is one of the main ways. They've also shared information in prenatal classes, which is a great idea. And then, so any hospital space where birthing people are coming is a great way to share it early on, and then giving it to the patient in their admission folders. Next slide, please. And this is how hospitals are trying to encourage patients to complete the PREM survey. Again, this information is all from our annual survey, which happened late last year. So I'm sure teams are learning new things all the time, but they put it as a goal for the day on the whiteboard. I think it's a great idea. They offer an electronic device to patients to complete the survey if they don't have one or if their phone's not handy. They have a designated person. So in one hospital, a primary nurse discusses and follows up with the patient on their completion of the PREM. That's what we're talking about, an important part of the process. They also hang the QR code in all the postpartum rooms. Providers commit to reminding patients throughout their stay, and then they have it placed. I've seen hospitals place it both in the admission folder and discharge folder. Next slide, please. Okay, so I wanted to make sure everybody knew that we do keep all of our materials publicly available. You may need some help navigating them, and happy to help with that. But on our website, there's initiatives and there's a birth equity page to the ILPQC website. Once you scroll down, there's toolkit, and the resources are organized by the drivers and strategies. You just keep scrolling, you'll probably find what you need. So thank you so much for listening and having me, and I'm happy to take any questions or whatever is helpful.
Thank you so much, Patty Lee. Oh, we do have a question coming in. So a few questions. One, is the staff education formalized so that continuing ed or CME credit is given? The second question is senior management and the hospital boards also involved in this education and sign on? And then the third is how will this be sustained?
Good questions, thanks. So for the first question, we provide resources for hospitals to implement for education. There's a couple different types. One is we recommended 2 e-modules based on our review of all of them that were free. We were really trying to focus on scalable, accessible e-modules for that piece. And diversity science, the free version does not come with CMEs. The fee version does. I don't know. I don't think so. Hospitals, we did enter an arrangement with Diversity Science. So Diversity Science can help hospitals implement the e-modules into their EMR. And I think at that time, hospitals can choose if they want to purchase the fee version to have that implemented in their EMR and offer continuing education, contact hours, or not. So it's really up to the hospitals how they want to pursue it. But the tools we have are available through other providers. There's also Think Cultural Health through the federal government. So it's really up to the hospital teams now for the modules. Now for the other things like the grand rounds that we offer, they typically do offer CME credits for that. So they contact us in advance, and if they have one of our speakers or their speakers, they set up to offer continuing education CMEs for the grand rounds, but the hospital facilitates that. We provide the tools and the hospital gets the CME credit. For the second question, senior management and the hospital board also involved in this education and sign-on. So it's a good question. Many hospitals, as I'm sure you all know, have diversity, equity, inclusion offices, more and more, just good and good. And they also have implicit bias education for maybe more broadly. So yes, many of our hospital teams do work with senior management to integrate this specific obstetric offering, because the tools we put forward are really related to birth equity, not equity more broadly. I mean, emphasis on birth equity with examples that are very tangible in that area. And so they do, but I don't know that they have to if they want to integrate into their learning management system. And then others find ways to just do it directly through their unit. So it really depends on the hospital. And then when we ask how this will be sustained, certainly there's lots of ways for me to interpret that. When it comes to education, which I'm assuming it is, given the context of the first two questions, sustainability is a really big piece of what we do. I think the integration into the learning management systems is a part of it. Most of our hospital teams from past initiatives have an ongoing module in their continuing education and their new higher education for the ILPQC initiative. So once they've completed the initiative and as they move to sustainability, part of their sustainability planning with us is implementing ongoing education on in these areas, both again for continuing education and then new hires as well. So we do a sustainability plan where that is like 1/3 of the work is coming up with a plan for that. So it'll be sustained through the hospital's choices, but it's definitely an intentional process that they take. Looks like there's another question in the chat.
Yes. A question about whether community advisors give any evaluation of their experience participating in those advisory meetings, and if so, what sort of feedback have you heard?
Yeah, so the ones that we hosted, the regional community engagement meetings, and that some of you may hear about through other channels. Yes, they did. There was a survey distributed to both the hospital team participants as well as the patient and community members. And the patient and community member feedback was very strong. I think I have the survey data and I don't have it up in front of me, but of all of the people that completed, all of them there was no negative experience reported. It was all positive. And the things that they observed were kind of their interconnectedness with the systems around them, the opportunities to collaborate, and they did find value both in sharing their voice and hearing the other perspectives. So I was excited to see that. Now that was done with support from a community partner, in an environment that we intentionally created to be positive for them. So I think that, that shows that intentional way of bringing in patient and community members, clarifying roles and providing opportunities. And it was really centered around their voices. Definitely was a positive experience for them.
I have a quick question.
We did
go ahead.
No, I was just gonna say we did compensate them for their time as well. So.
Thanks, Patty. Just a quick question. I don't know if you've heard this, but for hospitals that have implemented the commitment to respectful care and the PREMs, have they noticed any improvement on perhaps measures that were in place before that? So HCAHPS or anything like that? Just thinking about positive reinforcement, even for like C-suite stakeholders.
Yeah, I do not know the answer to that question. I think that's a really good one. We're really focusing on the PREM that we've rolled out. There certainly was a lot of discussion early on about how this is distinct from HCAHPS. And so we haven't heard any report of that, but I would say we're still relatively early. There's probably only a handful of teams that are at the point where we could maybe ask that. And I could see if we could find some insights on that, but offhand, I don't know.
Thanks. Any other questions?
Yeah, it looks like Tina put in a link to one of the modules we recommend, and then diversity science is another free one as well. That we pay for help with integrating into learning management systems, but it does exist on its own too. For free.
Patty, I just wanted to ask you, hi, my name is Misha Severson and I work with the Team Birth Project, and we do some of this inpatient surveying as well. And it's a big lift for teams. It can be a lot of work. And so I really loved hearing some of the strategies and different things that you shared. I'm wondering, and it's fine, obviously, if you don't know this, but just do you happen to look at each site and kind of, do you have a rough estimate or a goal for sites about return response rates and percentages, and like where you get the denominator for that?
We've just been talking about that because we're starting to define our QI excellence awards for our teams for birth equity. So for each initiative, when we have an award that indicates they have achieved the goals of the initiative and are ready for sustainability, and we call it an award of excellence. And the criteria to us indicate what is a successful completion of this initiative look like. And that's where it came up. So the way we calculate it is they provide their birth volume for each month. Then we track the PREMs that they've completed, and numerator is PREMs completed, denominator is births for the month. So ideally, you want as many as possible. I think we're looking at around, we haven't decided yet, but I think we're hoping at least 30% completion. And again, knowing that this isn't a study where we're going to get every single individual to participate, but enough that gives feedback for reflection and intentional improvement efforts. I think we've talked in the 30 to 50% range, but it is, as you've suggested, it is hard work. And
Yeah.
I think we'll have some hospital teams that can get to 30. Right now we only have one that's in that realm. So
Yeah. I agree. I think that is 30% is a good aim for teams as well. So anyway, thank you for sharing.
Thank you.
Thank you again, Patty Lee. This has been phenomenal and super helpful. And just a reminder to everybody that this has been recorded, and both the recording and the slides will be available on our website. So you can certainly come back and revisit. But I will now pass it over to Claire, who's going to wrap us up with some announcements and upcoming events.
Yes, thank you, Kristen. And thank you, Dr. King, as well. That was a great presentation and very timely, as many of our teams are working with Team Birth and thinking about launching Team Birth very soon. So thank you so much. So as a reminder, next month, March 21st, we'll be having our next monthly webinar, and this one will be focused on bias and respectful care, and it will be led by the New York PQC people who have also worked with Dr. King's group in creating those respectful care guidelines. As a reminder, CME and CEU credits are available for previous webinars, so you can head to our webinar recording page and claim those credits. Very exciting. We have our spring summit on April 12th. It will be in person in Norwood. So please register if you haven't yet, and share with anyone you think might be interested in this. We have some great speakers coming, mostly focused around the equity work that PinQuin and our partners are doing. And so it's very timely with this bundle. And we are asking people to watch Aftershock if you haven't seen it yet before the summit, since we will be having a panel discussing the documentary during the summit. And if you do not have access to Hulu yourself, we will be doing a virtual screening of it the night before at 8 p.m. And you can register through a link that Kaylee has just dropped in the chat as well. As Kristen said earlier, we are thinking about our next bundle and would love to hear what you all think and what you're interested in engaging in next. So please do the interest form to let us know. So some other events happening. So in response to a Joint Commission report recently, LSU is going to be having a webinar discussing the needs of the communities and how we as healthcare providers can address those needs. So you can register with that link. There is also going to be 2 in-person workshops for through the Nurse Midwife Vermont group. So here's some information there in March 11th and 12th, and you can register with the links that Kaylee is dropping. As you have heard us say many times before about the lovely Speak Up trainings, the Champions trainings is the first step in the pathway. And so the next ones will be May 3rd and 10th. It's a 2-part series. So you have to go, you are requested to go to both days. There are continuing education credits available for those. And this is a free training for Massachusetts providers. And then the next step in the pathway is the ambassador training, which is a 1-day training. And those will be offered in both April and May. So you can choose to go to one of those if you would like to continue your pathway and training with Speak Up, which we highly recommend. As we saw last month, there are many hospital groups that are still working on their anti-racism statements and need maybe a little bit more guidance with that. So definitely head to our website and check out the webinars that we did with PQI about creating anti-racism statements, also collecting data and disaggregating, and many other measures that we're focused on for this webinar or for this bundle. If you have not seen the hypertension bundle webinars, those are still available and you're able to get continuing education credits. So definitely share and watch those if you haven't already. Thank you everybody so much. Please reach out to Kaylee or I if you have any questions. We are here to support you all.
Thank you, everyone. Thanks again, Patty.